Can you hear me now?
Yes, sir.
A lot better? Okay.
Much better.
Okay. So for those of you who are studying for boards, Diseases of Swine was published in '92 and has done a very good job with many of the diseases that you'll need to have basic information for boards dealing with swine respiratory diseases. However, what I've done, the approach I've taken is between Dr. Stevenson and myself, we ripped out quite a few of the articles from some of the pathology journals and have supplemented the information in Diseases of Swine, trying to update it for 94, 93, 94, and maybe a couple articles from 95. Let's see, there is a handout. Paul, do you distribute that? Okay, and so you've got this handout. All I've done with this, some of the diseases I'm going to talk about have had articles published. And like I said, I've tried to stay with some of the journals that would have actual lesions described and hopefully some of the pathology or at least pathogenesis discussed. And I haven't really focused in on microbiology articles. So the journals that we've really focused on are Journal of Veterinary Diagnostic Investigation, that's JVDI on your handout, Veterinary Pathology, JAFMA, and AJVR. So with that in mind, we'll get started, and you won't have to write these references down as we go. Much of the information that I'm going to present is summarized in the articles that I've picked out, and there are many more than this in the literature you'll need for the boards, but the articles I've picked out here are generally review type articles that will bring you up to speed fairly quickly. Okay, we are talking about respiratory diseases of swine to start with. There's really nothing special about the swine lung. I just wanted to mention to you that I'll be talking about the lobes, and I will usually use cranial, middle, and caudal lobe to demonstrate or discuss the individual lobes of the lung. You may know them as apical, middle, or cardiac, and diaphragmatic. So the bottom line on it is I will probably switch back and forth during my talk. If you do, at least you'll know what I'm referring to. The pig does have complete lobulation of the lung, so bronchopneumonias tend to be well demarcated and are usually pretty easy to distinguish. The first disease we'll talk about is atrophic rhinitis of swine. Two organisms have been primarily implicated in atrophic rhinitis of swine. Bordetella is a very easy colonizer, has manosensitive receptors in the upper respiratory tract of pigs. But it's not associated with a severe atrophic rhinitis. It may produce a transient atrophic rhinitis, and there's strong evidence that there's regeneration if Bordetella bronchoseptica is the only organism involved in atrophic rhinitis. Atrophic rhinitis affects pigs that are usually 2 to 5 weeks of age, and during that time what you'll see clinically is just some sneezing. Unless it's a severe disease, then you'll see epistaxis. The organism that's most commonly associated with progressive atrophic rhinitis, which is the term Diseases of Swine has embraced, is the Pasteurella multocida. Pasteurella capsular antigens A and D are the most common in swine, and they may or may not produce toxins. Pasteurella D, the toxigenic strain, is the most commonly associated isolate with atrophic rhinitis. The toxin that it produces is a thermolabile toxin, and it can be demonstrated. There are tests that can demonstrate the toxin based on an ELISA test or DNA probes or mouse inoculation studies. This is a normal turbinate. In swine, they have very full scrolls in the nasal cavity. The turbinate is composed of a mucosa overlying a central osseous core. The osseous core is the heart of the lesion here for atrophic rhinitis. What occurs is we get bacterial colonization, and Pasteurella multocida is a poor colonizer of the nasal turbinates, and actually usually requires some type of an initiating factor, perhaps cytomegalovirus or dry air, some other irritant to assist in developing a small rhinitis. And the bacterial colonize on the surface. There is no penetration. The toxin that has been isolated from Pasteurella type D can produce atrophic rhinitis in its pure form without the bacteria, injected or intranasally instilled. So the toxin is vital to the pathogenesis of the lesion. Essentially what occurs is the pig is born with a cartilaginous core in the nasal turbinates, and that core has to ossify as the pig gets older. That occurs between 1 and 5 weeks of age. The toxin itself destroys osteoblasts. Ultrastructurally, there are lesions in the osteoblasts, usually swelling of the membranous organelles and actual necrosis of the osteoblasts. The lesions that are seen histologically reflect that. Essentially, the cartilaginous core is partially replaced with bone in a progressive manner. However, when the osteoblasts are destroyed, there's decreased osteoid produced, and hence the bone or endochondral ossification is reduced. In addition to that, and I've never seen a chondroclast, but apparently chondroclasts, according to the literature, and osteoclasts are active in removing any other bone and much of the cartilage that's present in the cores. Therefore, structural integrity is eliminated. And this occurs most commonly in the ventral scrolls, and then later in the disease in the dorsal scrolls. The lesions that we see here then is malformation of the turbinate bone, so turbinate bone hypoplasia. The morphologic we would see grossly is turbinate or conchal atrophy, and that's the morphologic I would use for this. In addition, there's deviation of the septum and deformation of the snout, so we could have several morphologics, the turbinate atrophy and septal deviation based on that. Now, in addition to the removal of what little bone is there, damage to the cartilage, damage to the osteoblasts, there's a mesenchymal proliferation and basically a fibrous replacement histologically of that scroll. I wish I had a picture of that to show you, but I do not. Various isolates cause varying degrees of damage. This shows a rather wide range. There are established rules and guidelines by which snouts are graded and scored in an attempt to reduce atrophic rhinitis from a management basis. Atrophic rhinitis can be very severe. Economically, during the period where the pigs are actively infected and there is an active rhinitis, clearly they are depressed, there is a reduced weight gain. However, by the time they reach maturity and are marketed, oftentimes they can compensate for that. So the economic cost associated with atrophic rhinitis, at least in the literature, has been questioned. In addition to the atrophic rhinitis, oftentimes maxillary bone doesn't grow as fast as the palate, and what you end up having is the snout becomes raised or twisted. Deviations can occur based on the septal deviation. Structural deviations can occur in the snout. Oftentimes there's wrinkled skin on the snout and occlusion of the nasolacrimal duct, and there's oftentimes tearing and staining of the face with dark brown secretions, and you can get a hint of that right here. So that's atrophic rhinitis, progressive atrophic rhinitis. The primary problem there is Pasteurella multocida. Inclusion body rhinitis or cytomegalovirus infection, that's a beta herpes virus. They're well known for their slow growth and their ability to produce cytomegaly in cell culture. They produce distinct inclusion bodies. I suppose I read a report where 90% of the herds in the United Kingdom are infected with the virus, and in well-managed herds, basically the economic significance is very questionable. This affects pigs that are 1 to 3 weeks of age, and clinically what you have is sneezing and excessive tearing of the eyes. Apparently, many times these are inapparent infections. The primary site of viral replication and the primary site we see inclusion bodies is in the nasal mucus glands. You see these very large, deeply basophilic inclusions that essentially obliterate the nucleus. As a matter of fact, you have to search around and find a normal nucleus because they can be so numerous. Oftentimes, they'll completely line the glands, and you'll miss them because they're so numerous. You can see this particular inclusion is almost twice again as big as the size of this nucleus, and there are many present in this gland. Another example of the very same thing, really very deeply basophilic intranuclear inclusions, and there oftentimes is a mild rhinitis that'll go along with that. In severe cases, perhaps even some metaplastic changes in the nasal epithelium, but usually just a low-grade lymphoplasmacytic rhinitis associated with cytomegalovirus infection. It can be a systemic disease. That's probably uncommon, or if it is common, then it's probably not a clinically significant disease, because inclusions can be found in the Brunner's glands, in the duodenum, salivary glands, in the renal tubular epithelium, in some endothelia, and occasionally in the brain. Rarely there have been reports of cytomegalovirus causing an encephalitis, but as a general rule, it doesn't have much of a systemic effect. An uncommon condition, Dr. Stevenson showed you where the needle teeth were clipped on pigs, and there was a stomatitis associated with that. That perhaps is the portal of entry for bacteria, but this happens to be bullnose or a paranasal abscess. Oftentimes, cranibacteria will be isolated from that. Sometimes fusobacterium will be isolated from that lesion. But basically, it's just a large paranasal abscess. Cell-associated respiratory bacilli. There's not much out in the literature in pigs. The slides I got from Dr. Neatfeld from Kansas State University. And he presented this paper, and there's an abstract in the 1995 AASP Swine Practitioners Proceedings. Apparently, the carbacilli are more common in laboratory rodents. Flavobacterium and Helicobacter have both been implicated based on DNA homologies as being causes for this disease in various species. These are gram-negative bacteria that are grown in cell culture. They apparently won't grow on free agar. In the cases that Dr. Neatfeld investigated, they had about 90 pigs that were submitted from 2 diagnostic laboratories where they examined the tracheas for carbacilli. In each case, there was a tracheitis and respiratory disease associated with the farm, and other pathogens in every case were found and considered causative agents. So whether the carbacilli were part of the problem or not was unclear. I don't know what the age of the pigs were. I'm assuming they were grower-aged pigs that they investigated, but approximately 50% of the pigs that they looked at had evidence of carbacilli based on silver staining of the tracheal epithelium. And if you'll notice, there's really not much of an inflammatory response in this particular slide, and that's rather characteristic of what he described, that the inflammatory changes were minimal. They could attribute the respiratory disease to other pathogens. Their attempts at isolation and reproduction of the disease have been difficult. Apparently, there's a lot of mycoplasma contamination of these, and they can't seem to get them in pure culture to try to fulfill Koch's postulates with that. Based on PCR and immunoperoxidase testing, it appears that the swine carbacillus is not the same species as that in the rat. The speciation is totally unknown at this time, especially because there have been no transmission studies done. In rats, they do cause, apparently, decreased ciliation and some degree of parabronchial cuffing in the lung. So they may have an effect, and it may be mild, but time will tell. The pathogenicity of the carbacilli is questioned. The lesion is essentially a lawn of bacteria that are apparently parallel to the cilia. And ultrastructurally, you can see these are gram-negative organisms that are lying adjacent to cilia and that are just a little bit bigger than the cilia. Same thing here. Maybe they're approximately the same diameter, but they do have a gram-negative cell wall. So these are gram-negative bacilli. Pigs do get cilia-associated respiratory bacilli. To my knowledge, that's not out in the literature yet, so as far as a board question, I don't know. However, if you're looking at trachea from a pig, that's certainly one thing you're going to want to consider. This happens to be a mycetoma, a large inflammatory polyp essentially on the tonsil of a boar. He was sent in because of difficulty in swallowing, lost a lot of weight. That's an unusual finding. The only reason I put it on here is because histologically we did find this to be a mycetoma. Here, bacterial colonies surrounded by inflammatory exudate and fibrosis. The bacterial colonies have that typical Splendor-Hopeley reaction, and there are a variety of bacteria that should be included in the differential, like different actinomyces and actinobacillus and nocardia. This happened to be actinomyces pyogenes. We isolated from this. Many of them were gram-positive, slightly slender rods. And I put this on there just to remind you that, at least when I took the boards, there were probably 10 to 12 points over the entire pointage of the boards that were related to knowing different tissue reactions or bacterial reactions to various stains. So I'd encourage you to beef up on that before you take the boards. This pig had swine influenza virus and was coughing like mad, and this happens to be a submucosal hematoma. This is unusual. Just moving down the respiratory tract to get to the lungs, occasionally in the trachea, we'll see small hemorrhages and edema. This happens to be one manifestation of edema disease. This is a life-threatening situation. Oftentimes, pigs will be barking, and then when they actually die, there'll be occlusion of the larynx based on the edema. You can see the glistening appearance to the and the reddened appearance to the larynx. Trachea, larynx. This is a necrotizing or fibrinonecrotizing laryngitis is the gross I would use on this, or laryngotracheitis probably, because there is fibrin extending down. If this was a cow, you would expect IBR virus, which is a herpes virus, but it's not, it's a pig, so it's pseudorabies virus, which is a herpes virus. One of the diseases that was emerging at the time diseases of swine was being published is PRRS. So I'll spend more time on PRRS than any other. As a matter of fact, as we started pulling articles and going through the literature, most of my files were about that thick. PRRS file was about that thick. As a matter of fact, since the isolate of this virus about 2.5 to 3 years ago, there's been over 400 articles published on PRRS virus infection, ranging all the way from clinical to molecular evaluation of the viral genome. So I'll just give you a very brief overview. I can't even hardly touch it here, but we'll discuss it in brief. I have provided a reference that in 1994 was, I think, one of the most complete references on PRRS virus, and I would encourage, if you're interested in that, to obtain a copy from the library. That's in Swine Health and Production, 94 page. It's an 18-page article, and it was written by Bill Christensen. This is essentially his literature review for his PhD, but it's really quite complete and well done. PRRS virus has been isolated. It's been classified as an arteriovirus. Here we can see it's about a 75 nanometer round virus, approximately spherical, with about a 35 to 40 nanometer diameter nucleocapsid core, which is quite dense. It's a positively stranded RNA virus, and it's in the class of viruses that you would see with equine arteritis virus, lactate dehydrogenase virus of mice, and simian hemorrhagic fever virus. So it's a new virus to pigs. It's unusual. The virus has at least a limited number of cells that it can replicate in, which for many years was the reason we couldn't find a cause. It does replicate in porcine alveolar macrophages, and in, I think it's a monkey kidney cell, MA104, and then there is a cell line 2621 in the literature that's been, and I think that's probably an MA104 cell also. A little bit of history. In 1987, there were outbreaks of a reproductive problem that was described in North Carolina. And it spread throughout the United States in a rather rapid fashion. We experienced it in Indiana in 1989 as rather explosive reproductive outbreaks. Transmission by filtrates to notobiotic pigs was completed by Jim Collins in 1990. And it was about that time that Stan reported to us that we had the same disease in Europe. And the Lilostad virus, which is one isolate of PRRS virus, was isolated in pulmonary alveolar macrophages in July of '91. Within 30 days, most labs in the United States could isolate the virus, and we're isolating the virus in pulmonary alveolar macrophages. And then it was put on an established cell line, the 2621, and that was the first report of getting this virus growing in an established cell line. So we've only been talking about having the virus isolated for several years. Just a few things. The viruses in Europe are slightly different than the ones in the United States. Serologically, they're distinct, and in the United States, the number of herds that are infected where serology has been done, it seems to be staying around 10% of the herds have what appear to be the European isolate. The U.S. isolate type strain is in most herds in the United States, but there's cross-reaction for the majority of herds. So from a serologic standpoint, the serology tests can pick up most of the infected herds in the United States, but there are a few where the serology will not pick it up. Original descriptions were of a reproductive failure syndrome, and I'll touch on that briefly, even though we're talking about respiratory. In Europe, abortus blue was one of the names because of the marked cutaneous cyanosis associated with the sows. It is a reproductive problem. As it turns out, from a variety of authors, it's been shown that the placenta acts as a pretty strong barrier to infection, at least through mid-gestation. The pigs are susceptible. In studies by Mingling and Lager, they actually infected pigs in utero. However, in the first trimester, and the pigs were susceptible to infection. But under the exposure of the sow and viremia, the placenta acts as a barrier at least until mid-gestation, and it's at that point that the fetuses get infected. And if the fetuses are infected near mid-gestation, they're oftentimes carried to near term and will end up with mummies. If they're infected a little later in gestation, they'll often die and we'll get stillborn pigs. And oftentimes there are live pigs that are weak or thumping, or they may be normal. And those that are normal oftentimes will be viremic up to 8 weeks following birth. Many of those will be susceptible to secondary diseases and die prior to weaning. This is typically what a PRRS litter will look like. You'll have some pigs that are large and swollen. They have died. There may be the start of mummification. More normal appearing pigs, and within the same litter there may be even a live pig and a mummy on each end of that. So there may be pig-to-pig transmission within the uterus. Just a few points about the disease that are a bit unique, and again I hope some of the references that I gave you will cover this quite well. This is an interesting disease because pigs that are young pigs that are infected with a virus are viremic for long periods of time, in some studies up to 8 weeks. That's a long time for an animal to be viremic. And that's viremic in the face of very, very high serum antibodies. So again, that's one of the more unique features, and I could certainly see some board questions coming out of that. Sows can transmit the virus to sentinel pigs. There have been pigs inoculated and PCR analysis done on tonsillar tissue where the virus has been detected out to 200 days or beyond. So it seems to be a rather persistent virus. A few things about the boars. Boars, kind of ignore the slide for a second. Boars This is an old slide, and the literature's been somewhat updated. Boars infected with PRRS virus are viremic immediately after inoculation, say within 24 hours, and for 14 days. The PRRS virus can be found in the semen starting as early as 3 days. Almost all the boars were infected by 5 days, and there was PRRS virus isolated from semen up to 43 days. So even though the boar may not be actively viremic, it is present in the semen. That has some rather profound implications for transporting semen, and the breeding industry's up in arms and trying to figure out how to deal with that. There is a PCR test at South Dakota State University that they look at semen. Isolation from semen has been particularly difficult. The pig is the primary source of transmission. Infected pigs, semen apparently can be. So can birds. Jeff Zimmerman at Iowa State did some studies where they were able to inoculate birds and recover it from feces for varying amounts of time depending on the type of bird infected. In our own laboratory, we went out to farms that were endemically infected, confirmed virus infection on the farm. At the same time, we trapped mice and rodents, and we were not able to isolate or recover PRRS virus from that. As a matter of fact, there was a big old tomcat one time when we were out there, and we grabbed him and bled him too. And he had been eating those mice and rats from what we could tell. At least that was the history, and he was negative also. In Europe, there was strong circumstantial information that suggested aerosol transmission from farm to farm was possible. Studies at Iowa State University have shown that that would be a difficult method by which to transmit the virus. I won't get into diagnosis of PRRS virus. We usually just, in pigs that are infected, 2 points. Number one, serum is a good tissue to isolate it from. So we have people draw blood and we isolate it from serum. Can be isolated from many tissues in the body as long as you have good fresh specimens. Very quickly the virus is inactivated. It's very heat sensitive. And that's precisely the reason why fetuses are very poor specimen to isolate the virus, because they often have died in utero. And if we have a fetus presented to us, even at body temperature, no more virus is being produced, and the virus is there, is quickly inactivated. So we rarely get virus isolation positive from fetuses. A couple things in the literature regarding lesions. Rousseau, and you've got that reference listed down there, had some interesting lymph node lesions in some pigs that were infected in utero, were born and then killed sequentially. In addition to the lymph node lesions, there was a myocarditis associated with this, but the lymph node lesions were pretty interesting. They found them in 4 of 13 pigs, and those 4 pigs were some of the older pigs. They killed them from approximately day 6 up to day 40, and it was in the older pigs that they found this. Polycystic degeneration of the lymph node. This happened to be an iliac lymph node. And there were multiple cysts scattered throughout the lymph node. Some of those were lined by endothelium and are probably dilated lymphatics. Others were not. One of the lesions he describes, you can see on this side, and these are just reproductions from the article. It's about the best I could do at this point without having tissues. The lymph nodes, there are a lot of more normal appearing lymphocytes over here, and many of the lymph nodes were hyperplastic. As a matter of fact, that's a feature that's commonly seen in PRRS, is we have a transient lymphocyte necrosis, but quickly lymph nodes become hyperplastic, and you can see small regions like this where you have many, many pycnotic lymphocytes, and that's about as dramatic as the lymphoid necrosis gets. It's a transient lesion, and lymph nodes quickly become hyperplastic, have prominent germinal centers. He demonstrated some interesting polykaryocytes. These are large cells with perhaps a dozen or even more cross-sections of nuclei in these large cells. And they were found at the margins of the large polycystic spaces that were not lined by endothelium. He makes a point in the article that these are also called Warthin, W-A-R-T-H-I-N, Finkeldi bodies. I've never heard of that before, or cells. And apparently these have been demonstrated in lymph nodes of humans with HIV virus and measles. So it's kind of an interesting finding, and who knows, perhaps something like that could end up on the boards. There are problems in looking at fetuses with PRRS. Most of the time you get in a bucket of fetuses and they've been autolyzed pretty badly, and the tissues don't provide particularly good histopathology. Dr. Lager did experimental studies where he had 4 litters that were inoculated and gestationally were allowed to go for about 3 weeks before the sows, they were taken by C-section. So he had live fetuses that they were removed by C-section and did histopathology on them. And they did demonstrate some lesions in the bronchial buds or developing airways in some of the fetuses. And I think it was in quite a few of the fetuses. They found it in every litter that they looked at. There was necrosis of this bronchiolar epithelium and the smooth muscle and the mesenchymal tissue adjacent to it, and oftentimes inflammatory cells adjacent to that. The other feature was this darkened exudate within the airways. So those are some features that diagnostically very few people will see, because you would have to have absolutely excellent fixation to see that. Butch, have you ever seen that?
I've seen things that I've called fetal pneumonia in aborted porcine fetuses where there was evidence of PRRS, but to be able to pick up that exact lesion, I don't know.
Okay. One of the things we noticed right away that PRRS virus weakens pigs to secondary bacterial infections, and as we went out onto farms, especially some of the breeder farms or grower farms, we would find pigs that looked like this. Some of the things we noticed with pigs were having very tremendous death losses due to simple bacteria or diseases like salmonella that could easily be controlled previously. They couldn't control with antibiotics. And it was at that time we started looking at these farms looking for the PRRS virus, and we actually did characterize the endemic infection with PRRS virus. Pigs that are inoculated with PRRS do have some immunologic dysfunction. Within a few days, usually by post-infection day 4, there is a lymphopenia and a neutropenia, but that bounces back pretty quickly. As I mentioned before, there may be some lymphoid necrosis, but again, that's transient. As a matter of fact, lymphoid hyperplasia is more of a commonly recognized lesion with PRRS virus infected pigs that are older. Some studies by Tom Molitor at University of Minnesota have demonstrated that these pigs are actually more responsive to exogenous antigens and have a greater delayed type hypersensitivity. So rather than immunosuppression from that standpoint, some of the cell-mediated immunity and at least humoral immunity appeared to be heightened. What does occur, though, is that alveolar macrophages are destroyed, and that first line of defense for respiratory disease appears to be pretty important to the pig.
I don't know why we see it, but it seems like we'll get a break on a farm and almost like clockwork, 2 to 4 weeks later, the place is breaking with salmonella, cholera. So
salmonella and Haemophilus parasuis are the 2 most commonly isolated pathogens we see.
It seems it's real constant.
Right, and that's typical. One of the things that occurred with this PRRS outbreak, with this new disease, was a real heightened sense of, hey, there are some other diseases we need to be looking at. And people started looking very closely at respiratory disease complexes in the post-weaning pig. And so 4 diseases I want to talk about looking at the respiratory diseases of the post-weaning pig is PRRS, swine influenza virus, pseudorabies, and porcine respiratory coronavirus. There is a 5th disease, the porcine paramyxovirus, that's had 1 report to my knowledge in the United States. And that was by Dr. Janke at Iowa State. And last week I was talking to him, and I have slides that I could have included, but he hasn't published the work yet, and their transmission studies haven't been as convincing as he had hoped, and he's still questioning whether it's a real pathogen. So I won't be including that today. That may be a virus that we will include in the future. A few things about porcine respiratory viral diseases. Most of these diseases affect pigs that are 6 to 12 weeks of age, so these are nursery and grower age pigs. They all have short incubation periods, and the net effect of that is a relatively explosive or noticeable outbreak on a farm. Replication for all these viruses occurs usually in the tonsil and or upper respiratory epithelium and or alveolar macrophages. So far there's not a whole lot of distinguishing characteristics for these viruses. They produce a viremia, except influenza virus theoretically does not. The coronavirus, the respiratory coronavirus, may or may not produce a viremia. That's not established yet. And they shed virus from the nasal passages readily, quickly, and for several weeks following infection. So again, on a farm, usually there's a rather rapid, explosive outbreaks. Morbidity is oftentimes high, mortality is oftentimes low. So what I want to focus in on are some of the features that might differentiate these. First of all, in PRRS virus infection, we don't usually have any coughing. As a matter of fact, one of the #1 clinical signs that's reported is heavy breathing. Versus influenza virus, where coughing, a dry hacking cough, is just classic. Pseudorabies, oftentimes you'll have pigs that are sneezing, pigs that are coughing, and pigs that are heavy breathing. I don't know that we can characterize that differently than the other two. Usually that's included as a differential for all of these. And then the respiratory coronavirus, interestingly, has few clinical signs, and it would, as a general rule, is a silent infection. The significance of that virus is now being explored. As pathologists, histologically, I think we can make a difference. You got to remember, all these have an interstitial pneumonia, usually an infiltrative interstitial pneumonia with some histiocytes, maybe a few lymphocytes present in the interstitium. There's oftentimes type 1 cell hypertrophy or swelling, and then following that, or even concurrent with that, would be type 2 cell hyperplasia. So it's almost a stereotypical response, but I think there are some things that we can separate. All of them have an interstitial pneumonia, and quite actually, I would probably, in my own experience with influenza virus and pseudorabies virus, make those 3 pluses, because an interstitial pneumonia is very common. However, influenza virus has a necrotizing bronchiolitis, which is uncommon with all of the others, and I don't think I've ever seen it with PRRS virus. That's a distinguishing feature. The necrotic alveolar exudate, and I'll show you some pictures of that. If I see that, I think of PRRS first, and that's certainly one of the things, even though it's not pathognomonic or not even specific, certainly PRRS is more common with that. With pseudorabies, punctate lesions, necrotic lesions in the respiratory tissue is what we're going to look at. So let's go through each one of those diseases. Again, interstitial pneumonia, just a slightly firm, slightly non-collapsing lungs, maybe a little bit more gray than you'd expect. Morphologic diagnosis I'd have for that on the boards, probably normal. But if I suspected it was a problem, I'd say interstitial pneumonia diffuse. This one being a PRRS virus, or a PRRS infected lung that we had just this year. And there's a lot more interlobular edema. I don't know if there was a secondary pathogen associated with that or not, but certainly a non-collapsing, very full lung and a lot more pulmonary edema. There have been some isolates that have shown tremendous, almost consolidation of the lung. Those have been reported by Iowa State University. But the vast majority of lungs are going to look like this. You really can't hardly see a lesion at all. If you're holding it in your hand, you can tell that it's a non-collapsing, slightly firm lung. Histologically, there's an interstitial pneumonia described as I just did a few minutes ago, an infiltrative interstitial pneumonia. There may be some type 1 swelling. And the feature that I want you to pay attention to is the darkened exudate here in some of the airways. And even at a higher magnification, with influenza virus, with pseudorabies. Oftentimes they're loaded with neutrophils, but this has almost pycnotic mononuclear cells. They're probably necrotic alveolar macrophages and probably necrotic pneumocytes. Interstitial pneumonia with this lesion. If I see that, I say, I'm really concerned about PERS. I would hope to do an isolation to confirm that. I have put in your, as a reference, a 95 reference by Dr. Halber that discusses the immunohistochemistry and does a pretty good job of reviewing the immunohistochemistry of PERS. Basically, this is some lungs that I infiltrated with India ink, but they would look very similar. It's to remind me to tell you that the primary cell that's infected with PERS virus and that's shown up immunohistochemically is the alveolar macrophage. They've also demonstrated some immunoperoxidase staining in the endothelium of the heart, but not really other places. In a paper that was just presented, and it's even in publication, they think there are lesions in the umbilicus also. But those lesions, and they were able to find some antigen in macrophages in the umbilicus. The other thing is lymphoid tissues, especially germinal centers scattered throughout the lymphoid tissues in distant parts of the body, will oftentimes have immunoreactivity. Swine influenza virus?
Bill,
Yeah.
seems to be the early reports of PERS were involved myocarditis and encephalitis.
We'll get to that.
And I don't think I hardly ever
Right.
see that on a clinical basis.
Experimentally, myocarditis has been reproduced a number of times. I'll show some pictures of that. I have slides from the University of Minnesota. Diagnostically, it's not been a feature that I've recognized either, and the encephalitis either. So I'll just tell you, it's not a common lesion, although experimentally it's rather readily reproduced. Orthomyxovirus infection in swine. Swine influenza virus is very common. There's a herd prevalence of greater than 50%. As I mentioned, morbidity is usually high with mortality low. This is a disease that can infect nursery-age pigs, but it's more common in the grower and finisher. These are type A influenza viruses. In the United States, the hemagglutinin and neuraminidase reactions are what we use to define the types of influenza viruses. H1N1 is the isolates in the United States that are most common. Europe reports predominantly H3N2. There are an antigenic variant that we'll discuss in just a moment. Again, diffuse interstitial pneumonia with hemorrhage is scattered throughout the lung. There's nothing spectacular about this. There usually is more hemorrhage and more lesion with influenza. This is diffuse alveolar damage. However, on cross-section, oftentimes there'll be some foam in the airways, but in the acute stages of influenza, you won't really find much exudate, and you also won't find much of a bronchiolitis on gross examination because this really has a propensity towards the terminal respiratory airways. Another picture of influenza, it can present with a lobular pneumonia. Now, you may want to call that a bronchopneumonia, but it really isn't because we have even high levels within the caudal lobes that are affected. And most of these lesions we're looking at here is atelectasis. So this is just a variation on it. And then another more subtle lesion, but again the same thing, atelectic lobules scattered throughout the lungs. And I will say that diagnostically we have to be kind of careful because if you take histopath of an area like this, you may miss it. You actually have to get down and choose the sections you're sending for FA and choose the sections you're sending for histopathology because the lesions may not be as diffuse as we would hope. And we go ahead and we will try to find the airways serving some of these atelectatic bronchioles. Where is SIV antigen? Where is it demonstrated? I got these slides from Dr. Vincent at Iowa State University. She shared these with me. Bronchial epithelial cells and airway exudate, alveolar macrophages, and upper airway epithelium, just as we talked about with nearly all of these viruses. We'll take a break in just as soon as I finish influenza virus. Butch, where are you going?
I gotta go.
Okay. Influenza virus, again, immunoperoxidase staining shows that the antigen's well present within the conducting airways, usually the smaller airways. And according to Jubb and Kennedy, this is a true description of what they call a bronchointerstitial pneumonia, where you'll have airway involvement, necrosis, so there's a bronchiolitis, and a disseminating or dissecting inflammatory response extending from that. This is early in the disease, and then when we get more diffuse alveolar damage and infection of type 1 pneumocytes, we're going to end up with a diffuse interstitial pneumonia. Some of the lesions we see with swine influenza virus, this is pretty typical. Disruption of the airways to the point of absolute necrosis of the epithelium. You can see here the epithelium's been totally replaced in this airway by necrotic cellular debris, neutrophils, and fibrin. And the airway actually is filled and distended with that. With time, the basement or basal layers of the epithelium will come over and try to cover the smooth muscle in the naked basement membranes of the airways. And so we get a quick and early regenerative response in the terminal airways. And then with time, we'll get a hyperplastic change where we'll get remodeling and stratification and then resolution. Oftentimes, there are hemorrhages within the lung. Again, within that necrotic exudate, here's a bronchiole that's necrotic. You can see the antigen that's present there. And if the damage is severe enough, you get a bronchiolitis obliterans. This is in a slightly longer standing lesion, and you can appreciate that there's more swelling of the type 1 pneumocytes. And the pig has a limited ability to create type 2 pneumocytes, but it'll approach that. And when we come back, in some of the upper airways, you'll get a metaplastic change in the more chronic stages of the disease. You can see residual antigen in this stained section here, and there's a squamous metaplasia of the airway epithelium in the conducting airways. When we come back, we'll talk about this antigenic variant and maybe even get Dr. Dunn to tell us a touch about what he's going to talk about in England. About 10 minutes of investigations of nurseries and grower pigs and finding a lot of different types of pneumonias. I have two references in your handout on an antigenic variant of swine influenza virus. And the reason they call this a variant, apparently this is a type A influenza, just like all the other swine influenzas. And it's weakly H1N1. Apparently the hemagglutinins have a very conserved amino acid region in them. However, these particular viruses have more variation in the hemagglutinin, and the neutralizing epitopes on the hemagglutinin are more varied. So they're saying it's not actually an H1, but slightly different than an H1, but it types out as an H1. That's about the most concise explanation I can give. There are some differences clinically. Apparently these pigs have very little cough. However, experimentally, it does produce a bronchiolitis and an interstitial pneumonia. The necrotizing part of the lesion is the bronchiolitis. The proliferative part of it is marked type 2 cell hyperplasia. The other distinguishing feature on this is that apparently these farms are infected and the disease lasts a particularly long time. I will say that I think since this article has been published, they found out that these farms were PRRS positive also. But they do have an influenza virus that they say is different. Stan, your experience in England, any different?
Well, yeah, our experience in England is completely different because your classical H1N1, which you've always said produced severe coughing and bronchiolitis and alveolitis, when it occurred in the UK in 1986, produced absolutely nothing. And neither the H3N2, which occurred in 1987. And it's only with the new variants, which is something called 195852, which is an avian strain that's completely adapted to pigs. That produces exactly the same lesions in our pigs as did your original classical strains. But since then, we've managed to get an H3N1, an H1N2, and an H1N7. And I think it's no coincidence that all this occurred within the 6 months after PRRS, because it completely changed the spectrum of respiratory disease.
Okay.
And everything was moving around. And since then, some of these produce absolutely no clinical signs, and some of them produce quite severe clinical signs. And the latest one we've got is an H1N2, where the H1 and the N2 components are from human influenza strains, both of which died out in the human population in the UK in the early 80s. So they've been living quite happily in pigs ever since. And one of our other strains, the N7, has actually come from a horse, which is the first time that the pig has been seen to be used as a reassortment for the horse as well. So I think once you start looking at these things, then things change quite considerably.
Sounds to me like the story is, the tale isn't told yet on that. And in the literature, be aware of these variations for the boards. Pseudorabies. It's been around for a long time. Diseases of swine does a pretty good job with it. I won't spend much time with it here. The pig apparently is the primary host. The lesion that we most commonly discuss with pseudorabies, of course, is neurologic signs. And Dr. Janovitz will cover that a little bit later. Apparently there is only one serotype of pseudorabies virus. The pig being the natural host for this would explain latency and subclinical diseases associated with pseudorabies. Some of the things we'll see in pigs can be age-related. Usually in the younger pigs, they'll get a rhinitis and sneezing, and that's always one of the differentials with atrophic rhinitis, is this pseudorabies present. Presently here is here's the hard palate, and here's the nasal cavity has been opened, and there's fibrin on it. So it's a fibrinous rhinitis would be the morphologic I would use for that particular lesion. As Dr. Stevenson mentioned yesterday, tonsillar lesions in young pigs, here's tonsillar necrosis. That would be the morphologic I would use for this, is a common pseudorabies lesion. Punctate necrosis scattered throughout multiple organs. Here the liver, you saw this picture yesterday. And I show you this because the next picture, you can get the same type of lesion in, but it's hard to see. And essentially what we have here is a non-collapsing, slightly reddened lung with a little bit of edema in it. And this is a pseudorabies lung with an interstitial pneumonia. So again, it's just one of those things that causes an interstitial pneumonia. A distinguishing feature might be these areas of necrosis. And you can see here the parenchyma here is essentially obliterated. The areas of necrosis can be the size of small bronchioles, so these can be relatively large, or they can be smaller areas of necrosis, perhaps no bigger than some of the alveoli in diameter, but the parenchyma is necrotic. A little bit harder to see here. There are some AFIP slides, I understand, that have better lesions than this, that are easier to see. Unfortunately, the slides that I had to take photographs of, which was last week, didn't turn out as well as I would have liked. But within those areas of necrosis, you can see there's just total dissolution of the parenchyma. And potentially, perhaps, maybe, you'll find some inclusions often are at the periphery. Dr. Stevenson showed some of those yesterday. I won't show any here because I'm not sure there are any. And I find that to be an uncommon finding in the lung. Another area of necrosis, so again, well-defined areas of necrosis, and I will say, I'm not sure if it's a function of the pig's age or the viral strain, but the older the pigs get, the more propensity there is for this to actually have an effect on the conducting airway epithelium. And it may try to mimic, although very minimally involve the epithelium, it may try to mimic influenza virus. But this is the more classic lesion. And if you get enough of these scattered throughout the lung, as you might imagine, you're going to have the entire lung involved, and it's going to look like an interstitial pneumonia, which it is. Respiratory coronavirus. Don't know if this is a clinically relevant disease or not. I suspect it's probably not. It affects nursery and grower age pigs. Interestingly, in the mid-'80s, our European friends saw a dramatic decrease in the amount of TGE that was being seen throughout Europe. And at the same time, titers to the TGE coronavirus was increasing. So they started going into some of these herds where they didn't have diarrhea but did have high titers, and we're able to isolate a coronavirus from the respiratory tract. Serologically, these TGE virus and respiratory coronavirus are indistinguishable using most tests that are available in diagnostic laboratories. The respiratory coronavirus appears to be a mutant of TGE virus. There's a 670 to 680 base pair deletion in the S protein, which is a surface spike protein or glycoprotein on the surface of the coronavirus. That deletion translates to two distinct antigens that are only on TGE virus, and those distinct antigens can be demonstrated both by PCR and by ELISA testing. So they can be told apart, the two viruses. There is some cross protection between the two. Respiratory coronavirus has some degree of protection when pigs are challenged with TGE and vice versa. The literature is a bit confusing and conflicting concerning to what degree that cross protection occurs. Diagnostically, how do we make the diagnosis? Well, the diagnosis is kind of a we fall back into it thing. We get an FA positive on lung. We have an FA negative on the gut. There's no diarrhea, and they have titers greater than 1 to 256. So putting all those together, we make a diagnosis. And alveolar macrophages and minimally within the gut. The review article that I just showed you from the compendium, which is listed in your sheet, I'd recommend you to read. The lesions I'm going to show you come from Dr. Pat Halber, and he's the one that did the original studies on this in the United States. The strain he used is about the worst strain they've ever found, and it has a different deletion than all the other strains of respiratory coronavirus. So these are probably much more severe than you'll find with most coronaviruses. His comment was, we usually don't see lesions grossly at all. But here, again, that modeling gray lung, the diffusely affected, if I saw that, I'd be more concerned about PRRS. Same thing here, small areas of gray discoloration, perhaps minimal atelectasis. We'll see that that's an interstitial reaction in just a moment. Hemorrhages are minimal. Histologically, the disease comes and goes quickly. Lesions are present in the lungs within 3 days, maximum by 9 days, and largely resolved with the exception of some residual parabronchiolar reaction by 15 days. Lesions are just as we described. Basically, there's a mild bronchiolitis and a parabronchiolar infiltrate. There is some alveolar exudate you can see here, and then just slight thickening of the alveolar septa. Again, the infiltrative lesion, which is minimal, but mainly type 1 swelling. Histologically, as the disease progresses, the lesions don't get much more severe. But again, this is being about the worst lesion of respiratory coronavirus that you'll see. Here we have some metaplasia of the conducting airway epithelium. And again, you just see some slight swelling of those type 1 pneumocytes scattered throughout the lung, and then increased numbers of desquamated cells and alveolar macrophages. The lesion I would have for this perhaps would be a parabronchial pneumonia or parabronchiolitis, but it is an interstitial pneumonia too. So this is, again, according to Judd and Kennedy, would be descriptive for the bronchointerstitial pneumonia.
How often do you see necrotizing hepatitis and pneumonitis in baby pigs?
The necrotizing hepatitis and pneumonitis with pseudorabies virus, you mean? In 100 cases of pseudorabies in baby pigs, 25% of the time.
Local lesions there?
Oh, well, I guess I can't really answer that as far as, I would say, yeah, probably.
Pretty common to see.
Very commonly seen together. As a matter of fact, usually I see the hepatic lesion and then I go back and I see it in the lung. Ascarid migration.
That's an Indiana pig, isn't it?
That's an Illinois pig. Ascarid larval migration, Dr. Stevenson covered, so I'm only going to spend a second on it. Again, a diffuse interstitial pneumonia here that on cross-section, I don't think we can distinguish from the cross-section I showed you with swine influenza virus. Hemorrhage is scattered throughout the lung, not much for, or there is no exudate within the airways, but just a non-collapsing lung with small areas of hemorrhage. The morphologic I would have used for that is a diffuse interstitial pneumonia. Histologically, there really is very little exudate within the alveoli. The lesion is usually a peribronchiolar eosinophilic pneumonia. And it's the interstitium, or peribronchiolar eosinophilic interstitial pneumonia is the morphologic I would use, because it's the interstitium surrounding the airways that apparently represents the path of least resistance for a lot of these migrating parasites. And in those areas, the interstitium is oftentimes expanded by large numbers of eosinophils, sometimes in just pure populations. And it says in the books that the ascarid larvae are commonly seen. In my experience, I rarely see them, but although they don't have any distinguishing internal structures, they do have the lateral alae that identifies them as an ascarid larvae. Salmonellosis, Salmonella cholerae-suis, we saw these same pictures the other day. Again, a diffuse interstitial pneumonia here with lots and lots of hemorrhage. The thing I'll point out is the pulmonary edema that's common with any bacterial endotoxemia. And I'm not going to say this is specific for Salmonella. That's clearly the most common bacteria that will cause this lesion in Indiana and in Iowa and in the Midwest. However, any gram-negative bacteria I think is capable of this. Dr. Stevenson showed you a picture of Haemophilus parasuis that caused this, uncommon. E. coli can cause this, uncommon, and I'm sure there are others. Hemorrhagic lymphadenopathy, and again, the lymph nodes are very hemorrhagic here. The pulmonary edema, the endotoxemia, the vascular disruption that's common with Salmonella cholerae-suis. This is one of the more common pneumonias that we'll see. Again, an infiltrative interstitial pneumonia, oftentimes lots and lots of neutrophils and lots of congestion, and then with time, lots of fibrin deposition in the lung too.
That growth picture could represent pneumonisin almost.
We'll see. We'll see that in a minute. Actinobacillus pleural pneumonia. This is a real costly disease for growth finishing pigs. Because it occurs in growth finishing pigs, it has a very peracute form. When I was at Iowa State, I injected some pigs with this stuff. These were washed bacterial cells, and they were dead 6 hours later. So it can be a very peracute disease. There are 12 recognized serovars. 1, 5, and 7 are most common in the United States. And some of them cause just a very minimum of lesion. And we'll talk about why in a moment. There are 2 biotypes. The thing that separates those biotypes is the requirement of that organism on primary isolation for NAD in its growth requirements. But biochemically and genetically, it's an actinobacillus, except for the requirement for NAD, and the lesions really are the same as type 1. So I'll show you, there's a recent paper in the literature that you may want to, I think I have it listed down there. Transmission is airborne. There are 3 toxins that are 3 protein toxins that have been identified with this, 2 hemolysins and 1 cytotoxin, analogous to the leukotoxin of Pasteurella maltosida, although I understand the Pasteurella leukotoxin is very species specific, and this one apparently is not. VetPath had a recent article where they developed a mouse model to look at the various toxins. And as it turns out, as these models have been developed and the toxins have been identified, these toxins are vital to the pathogenesis of the lesion. There is also an LPS associated with the actinobacillus pleural pneumonia. Classic lesion right here, a severe hemorrhagic or fibrinohemorrhagic bronchopneumonia. Another morphologic that would be equally and probably more acceptable is a fibrinohemorrhagic pleural pneumonia, because pleuritis is a common feature, consistent feature of this lesion. Tremendous vascular leakage causing this lesion. Another picture of the same thing. Be hard to call this a bronchopneumonia because the lesion here is massive. Almost the entire lung cuts like liver. Most of the time you'll find and anterior ventral distribution, and then hemorrhage is scattered throughout the rest of the lung. I show this to highlight the pleuritis, which is a consistent feature of the disease. If the pleuritis holds on very long, if the pig lives, you'll also have a parietal and a visceral pleuritis. Here we see tremendous amounts of fibrin on the costal pleura. With time, should the pig survive, areas of the lung that have become necrotic will sequester and become walled off, and this is what these look like. As you might guess, a lot of these farms are very chronically involved, and they will treat them with antibiotics, take them off, and then it comes back, and it says these things rupture, the lungs become fulminantly involved again. Some of those sequestrae, you get a thick wall, granulation tissue, and fibrous connective tissue walling off these things. And if the pig lives long enough, it'll try to liquefy and eliminate that sequestrum. Histologically, this shows pretty much most of the lesions in the acute stages of the disease. A fibrinous pleuritis, with time it becomes a fibrinosuppurative pleuritis. Lots of congestion and hemorrhage scattered throughout the lung. And then we get these well-demarcated areas right here where we have alveolar leukocytes forming a line or a barrier around areas of essentially caseous necrosis or necrotic tissue. Same thing here, very intense lines of demarcation surrounding congested but dead tissue here. And this is what will become one of the sequestra as if the animal was to live long enough. The hallmark lesion for actinobacillus is a vasculitis. In the mid-80s, Dr. Bertram published an article saying that the first lesions seen here is accumulations of platelets and then neutrophils on the endothelial surface. It appears as though the cytoxin, which is a heat labile cytotoxin, is an endothelial toxin. And then as the endothelium is damaged, apparently platelets will accumulate, neutrophils then accumulate, release their hydrolases and all the enzymes, and you end up with a pretty distinct and severe vasculitis. And even in all the very busy slide that these represent, you can find the vasculitis. Here, marked perivascular hemorrhage, as well as the vasculitis, inflammatory cells extending into the wall, swollen endothelium, and then the perivascular hemorrhage. That was a small vessel, and whether these are, I'm assuming these are venules, but I don't know for sure. A marked vasculitis, the wall's markedly disrupted. You'll get thrombosis of some of the vessels. This isn't a thrombus here, but you will get thrombosis of a lot of vessels. And then the marked perivascular edema, hemorrhage, and then the parenchyma itself, oftentimes very hemorrhagic, very edematous. This represents those firm black lesions we were seeing grossly. Again, the APP type 2, biotype 2, I don't think we can distinguish clinically. The distinguishment's based on growth characteristics. Pulmonary bordetellosis usually affects pigs less than a week of age, causes a very severe hemorrhagic pneumonia. Bordetella is a common inhabitant of the upper respiratory tract of pigs. Over 50% of the herds have bordetella on them, yet this lesion's quite uncommon. But in a pig that's a pre-weaning pig with a severe hemorrhagic pneumonia that looks like bordetellosis, or it looks like actinobacillosis, the primary differential is bordetella. Much of the same, a very severe hemorrhagic pneumonia with bordetella in it. Histologically, it can be a lobular pneumonia, but basically the lesion is massive hemorrhage in the lung, swelling of the alveolar septa, usually congestion, a lot of edema present, and you'll find a lot of fibrin thrombi in alveolar capillaries scattered throughout the affected regions. The books say that there's a bronchiolitis present. I have never seen a bronchiolitis associated with that, but these pigs are only a week of age or less usually, and so I say that that's what the books say. This particular slide really doesn't have much of a bronchiolitis, but this is a common lesion, the fibrin thrombi in the alveolar capillaries. And then the less affected portions of the lung, again, the edema, and then Type 1 pneumocytes become hypertrophic or swollen. And with time, with that much damage, you will get resolution of that. And anytime I see a bronchopneumonia with this antereventral distribution and the gray discoloration like that, I think of a chronic bordetellosis. This is the post-hemorrhagic lesion where most of the hemorrhage has been resolved. The pig has somehow or another lived, probably treated. And histologically, we see residual pneumonia in the whole thing, but a lot of fibrosis. And a fibrosing pneumonia in a early nursery age pig is usually associated with bordetella. Much the same thing, marked pulmonary fibrosis following bordetella infection in the pig. Glasser's disease, Dr. Stevenson discussed yesterday, and I will say that one of the primary differentials for any polysericitis would be Mycoplasma hyalinus, as well as Streptococcus suis and Haemophilus parasuis. Typical bronchopneumonia, and here's a pericarditis, 2 lesions that are very commonly associated with that, and polysericitis. I think we saw this picture yesterday. Dr. Webb?
I was just going to say with bordetella, I see a pneumonia that's kind of a mild pneumonia with pretty marked cupping of bronchioles with lymphocytes, no mycoplasma, real mild suppurative bronchiolitis, and just mild pneumonia that I associate with that and/or Haemophilus parasuis in youngish pigs. And we get that out without much else, you know. I mean,
The chronic bordetellas oftentimes will have a greater degree of parabronchial or lymphoid hyperplasia than any other pig its age. Mycoplasma hyalinus we'll see usually affects pigs 10 weeks or older, and in young pigs with this lymphoid hyperplasia, certainly bordetella is one of the things I'd be concerned about. Streptococcus suis is a primary pathogen in the United States. There are 29 capsular serotypes. This is something of public health significance. Serotypes 2, 4, and 14 can affect man and different ruminants, have been isolated from different ruminants. And most of the time we just describe a polysericitis, a bacteremia, and a meningitis with strep suis. But it does create a fibrinous or fibrinohemorrhagic pneumonia also, a bronchopneumonia. Clearly the airways are markedly affected here, filled with exudate. Not too much on the airway epithelium, but the airways, or the alveoli, are just completely filled with exudate and hemorrhage here. And again, I'm not sure I could tell that from bordetella. 2 articles you have the references for that was done by Dr. Reams here at Purdue University and co-authored by some of the people in this room, demonstrated after a review of the strep suis infections we had seen here at the diagnostic laboratory. They found that types 2, 3, and 7 were the most common that we found, and probably are the most common in the United States. 60% of the cases that they looked at had a bronchopneumonia as one of the lesions of strep suis. So strep suis does cause bronchopneumonia. It's a common cause. 20% of the cases they looked at also had a pleuritis. And so anytime I see diagnostically a case that's got a bronchopneumonia and a pleuritis or a pericarditis, I always make an attempt to isolate strep from that, as well as the Haemophilus being 2 primary differentials for that. However, they did find that in the cases they looked at, 70% of the cases had other identifiable pathogens with it. Some of the diseases that cause abscesses: Actinobacillus suis, Actinomyces pyogenes. Both are fulminant bacteremic bacterial pathogens that can cause abscesses scattered throughout the lung. These are multifocal pneumonias. And usually when I see an abscess, I try to isolate Actinomyces or Streptococcus. Strep equisimilis would be one of the things I'd be most concerned about there, rather than strep suis. Again, a cross-section with multiple abscesses scattered throughout the lung. Primary differentials: Actinomyces, Strep equisimilis, Actinobacillus suis. Histologically, this happens to be one where Actinobacillus suis was isolated. You can see that in the acute stages there's no walling of the abscess, but this is a microabscess that's formed. We get obliteration of the parenchyma, much larger than what we'd expect with pseudorabies, and much more neutrophilic. With time, that will form an abscess in its most classical sense. Histologically, in that same area, we see these clumps of bacteria that are gram-negative and a few gram-positive, so they may be mixed infections. But again, one of the things you want to do is to be able to tell the difference and know the difference between which bacteria are which on the board. Certainly, there'll be some points associated with that. The Actinobacillus suis, I don't want to talk too much more about because I really don't understand it. It's a septicemic disease. It's uncommon, and it's capable of causing what you see here is a septic vascular thrombosis. It can be a fulminant disease with hemorrhages throughout the body, but it can mimic the lesions of Actinobacillus pleuropneumonia too when it's severe enough. This happens to be a gram-negative organism, and there are some gram-positive organisms there too staining with it. Mycoplasma pneumonia is an effective bacterium on the market. Respiratory mycoplasmosis is caused by Mycoplasma pneumoniae. This is 70% of all herds in the United States are affected. In some studies, 99% of all herds, and within a herd, most pigs. So it's a very ubiquitous disease. Enzootic pneumonia is the disease of mycoplasmosis plus, and you name the pathogen, usually Pasteurella or strep or crinibacterium. This is an experimentally induced mycoplasmosis. This happens to be just pulmonary atelectasis, multifocal. That is the morphologic I would use for this one because I can clearly see that the lung is depressed compared to the remainder of the more normal lung around it. That's the early lesion of mycoplasmal pneumonia. But more commonly what we will see is enzootic pneumonia, where you see just the tip of the caudal lobe and maybe most of the middle lobe and most or portions of the cranial lobe affected. Oftentimes it'll have this slightly gray or just not quite red, but off-red color. Yeah, to use a kitchen term, fish flesh. If you cut that in half right there and squeeze it, a very thick white exudate will be exuded from that. More of the same. The organism stays right on the ciliated epithelium. It's a parasite of the ciliated epithelium. Causes a low grade to a severe bronchiolitis, oftentimes with increased numbers of inflammatory cells in the early stages under the ciliated epithelium. And there is the organism, again, intimately associated with the microvilli and the cilia in the pig. More classic lesion, what we generally expect to see with mycoplasmosis is a severe bronchiolitis of both large and small airways. There's oftentimes a marked infiltrate in the propria submucosa and a parabronchiolar infiltrate here, almost a lichenoid infiltrate, evenly flowing around the airways. And that's composed predominantly of lymphocytes, but lymphocytes and histiocytes. And then there's the suppurative bronchopneumonia that goes along with that too. Essentially, airways will be, our alveoli will be filled with fibrin, neutrophils mainly in the early stages of the disease, then replaced by histiocytes. And then somebody asked the question earlier, yeah, we see syncytial cells with these quite often too. In the resolving lesion, very severe parabronchial or lymphocytic cuffing. That's probably the morphologic I would use for it. For the other lesion, I probably would have said a parabronchial or lymphocytic interstitial pneumonia and use a second one of a suppurative bronchopneumonia or whatever the exudate would have been. Lungworms, metastrongylus in pigs. I say species because every book I've seen clumps them all together. Is elongatus, which the old name was apri, pudendotectus, I like that name, and salmi. I don't have any histopathology of this particular lesion, but Grossly, this is pretty classic. You see the atelectic areas all the way along the periphery of the lung. Pretty classic. Adjacent to those areas of atelectasis is this area of emphysema, or more almost hyperexpanded lung, and then this would be the more normal lung down in here. Same thing here. Again, atelectic areas here, more expanded emphysematous lung, and then normal lung peripheral to that. This is a pretty classic picture. You see that a lot whenever we see metastrongylus.
Is that a Missouri pig?
No, these are Indiana pigs. The parasites are very thin, very small, and they can get down into small airways. You'll find both adults and eggs within alveoli and smaller airways. So they are clumped up into the smaller airways. And to show the size, I've dissected a couple of them out here. Again, histologically, you'll find embryonated eggs and thick-shelled eggs both within the parasites and within the parenchyma. They have the polymyarium, coelomyarium musculature, and they have an oligocytous gut, syncytial gut, multiple nuclei, few cells, and a minimal microvillus border. It's just a typical metastrongylid. Very easy to identify. Dr. Webb mentioned that the salmonella lung would look much like the fumonisin lung. I've given you a couple of references about fumonisin only because diseases of swine doesn't do much with it, and it's a relatively new disease. There's still a lot of work to be done on the pathogenesis of what goes on. In this field report, Dr. Harrison was kind enough to send me these slides, and the lesions are really massive pulmonary edema. Massive pulmonary edema. There's also a hydrothorax. And I don't remember if there was a hydropericardium identified or not, but severe hydrothorax and severe pulmonary edema. Interestingly, the edematous lesions are limited to the lungs, and that's kind of giving you a differential for edema disease. Edema disease would have lesions all over the body, or edematous lesions could be present all over the body. Fumonisin B1 is a metabolite of Fusarium maniliforme. This is an acute lesion. Also, with this particular lesion, you can find histologic evidence of pancreatic necrosis in the acute stages of the disease. Histologically, massive pulmonary edema. Apparently, there is microthrombosis of septocapillaries too. I have to admit I didn't pick that out from the slides that were sent to me. The dose associated with this disease is 20 to 300 micrograms per gram of feed that was fed. 2 studies that were done, both injecting and feeding it, they were able to easily produce the lesions with 20 micrograms and 100 micrograms per dose, per gram of feed. In the more chronic stages of the disease, Dr. Osweiler demonstrated that there was hepatic lesions associated with that. The hepatic lesions were multifocal necrosis, disruption of the hepatic cords, and a megalocytosis. Dr. Stevenson discussed that yesterday. The 2 articles, I believe, are listed there that might be of use to you. One thing interesting to note, back when PRRS was being investigated, there was a lot of discussion as could this fumonisin be causing the PRRS lesion? Could fumonisin be causing the reproductive outbreak? And in the feeding studies done at Iowa State, they were not able to induce abortions using the fumonisin. An interesting article that came up about diaphragmatic hernias by Dr. Schwartz and JVDI. I have that listed out there for you. These pigs all were presented in respiratory distress, so I'll just mention that now. I found it to be an interesting article. He had 4 herds that they investigated. These 4 herds had pigs ranging in age from 5 to 16 weeks. And within the farm, within defined groups, they had anywhere from 25 to 75% mortality in those groups due to diaphragmatic hernias. In every case, the diaphragmatic hernia was on the right side, right at the junction of the muscle and the tendinous portion of the diaphragm. Within the article, he discounts congenital, hereditary, and trauma lesions for various reasons, multiple sourcing of pigs, and the age of the pig that was involved. And the fact that the lesions were quite chronic, or weren't necessarily chronic in the older pigs, but there wasn't a lot of hemorrhage or anything to suggest recent trauma. So he eliminated that. Several of the herds, they started injecting vitamin E, and the death losses stopped. Is it a vitamin E selenium responsive disease? He's making a suggestion of that, but he also said that they did check for Mycoplasma hyalinus in some of the exudate that was in the abdominal cavity, and they found it in a high percentage of cases. So there's a question mark. Is there an association with Mycoplasma hyalinus? I don't know. This happens to be a diaphragmatic hernia, and we have some organs, and I don't even know which ones they are, up into the thoracic cavity, and here is the lung pressed forward. So diaphragmatic hernia in pigs. Recent article in Veterinary Pathology. We were talking about dermatosis vegetans yesterday. Dr. Harrington showed some slides of that. And there is a giant cell pneumonia that goes along with that. Recent article in Veterinary Pathology. Apparently this disease is still alive and well in low numbers of pigs in Norway. He went to a lot of work to show that the giant cells are actually of monocytic, macrophagic, or histiocytic origin. So there's a recent veterinary pathology article that discusses that. But this happens to be the giant cell pneumonia, and this is the lowest magnification I have. I'm sorry, this is the highest magnification I have, but clearly an interstitial pneumonia. You can see alveolar septae thickened, and then these giant cells with multiple nuclei scattered throughout, there. And again, they went to a lot of work to show that there was a...
Is this a case, was that a case from here in Indiana?
This is a very old case from here, apparently from here in Indiana, yeah. Otitis media, and there's another article that kind of summarizes otitis in pigs for you. I don't know if Dr. Janovitz will talk about this under CNS. One of the problems with this whole thing is you don't know where to put some of these things, because if it's a eustachian tube, I guess that's in the nasopharynx, and theoretically it's respiratory, but theoretically it's GI, but usually it affects the CNS. So I'll just point it out here that a recent survey of otitis media or otitis in pigs showed a low percentage of the cases was an otitis externa. A low percentage was otitis interna. The vast majority were otitis media, and of those that were otitis media, many of them had an otitis interna. The organisms isolated, well, you can tell from the color of this exudate right here, there's probably Corynebacterium, or I'm sorry, Actinomyces pyogenes. There also is Pasteurella multocida isolated from those, and Corynebacterium group E, or no, Coryneiform bacterium group E, whatever that is, I'm not sure. And the majority of these lesions were bilateral in pigs, although the severity from one side to the other was different. Just to finish up this segment, had an interesting case where there was a barn fire in pigs. This is what we got into the diagnostic lab, and the history form said, what did they die of? I said, well, come on. You got to be kidding, right? And so I knew there was something going on beyond what did they die of. So I called the practitioner, and the point was, in the insurance contract with this particular farm, there was a suffocation clause. It's common in swine insurance cases where if baby pigs are laid on, they don't get paid. But there was a suffocation clause, and the practitioner needed to know, did these pigs suffocate? I said, oh, that's a good question. So I looked up in the dictionary, what is suffocation? And the dictionary said sea asphyxiation, which then I looked up asphyxiation and said sea suffocation. So then I got a different dictionary, and I looked up suffocation, or suffocate, and it said sea asphyxia. But asphyxia had this definition: the actual or apparent cessation of life due to interruption of effective gas exchange in the lungs. But the implication is that it's a mechanical compression. However, gas exchange can occur both on a gross level and on a microscopic level. So I didn't really know what to do with this, but the pigs did have some interesting lesions. There's marked pulmonary edema, so the pigs were probably alive at the time that the fire was going on. And then there was soot extending down the airways. You can see the black carbonized debris both in the glottis extended down. It extended down both bronchi. I got lots and lots of pictures of this. And all the way to the level of the alveoli, and histologically there's carbonized debris in the alveoli. So clearly the pigs were alive and breathing at the time the fire was going on. In addition, we took heart blood from some of these pigs, and they had carbon monoxide exposure and carboxyhemoglobin in the blood ranging from 58 to 78%, and anything greater than 15% is considered toxic and lethal. So the other interesting thing I found was, even in the fixed tissue, here's a piece of lung and liver from one of our pigs, the carboxyhemoglobin leached out into the formalin, and this is lung and liver from a pig that died from something else. I just had it for comparison purposes. You can see the distinct difference in coloration that lasted for 2 years in the formalin. The final diagnosis I made was smoke inhalation and carbon monoxide toxicosis, and I avoided the issue of suffocation, and to my knowledge the people were